So as Marie said, my name is Silvia Montoto. I'm the chair of the Lymphoma Working Party. And this is the third time that I have been invited to the Data Managers Educational session, and I'm very grateful. And it's a pleasure, but it's also a source of big stress, because I never know what the right level is for you. So, and whether this is what you are interested, what you wanted to know. So I would be very grateful if you please fill the feedback, even if saying this is not what we wanted to know and the level is either too high or too low or whatever. So these are my disclosures. And this is the outline of my presentation. I will talk first about lymphoma, what it is, a bit about the classification of lymphoma, why we have changed the classification and why it matters. Then I will give some details about the most frequent types of lymphoma: diffuse large B-cell lymphoma, follicular lymphoma, and Hodgkin lymphoma. I will move on to treatments now, and I will finish talking about the new drugs, the different families of new drugs, such as PI3 kappa inhibitors, BTK inhibitors, checkpoint inhibitors, BCL2 antagonists, and new monoclonal antibodies. So starting from the simplest question, the definition of lymphoma. Lymphoma is a heterogeneous group of malignant neoplasms that arise from the reticuloendothelial and lymphoid system. In a very simplistic way, we talk about Hodgkin lymphoma and non-Hodgkin lymphoma. The reality is is closer to this. There is some overlap, but for the sake of simplicity, we continue talking about non-Hodgkin lymphoma, which is a very very big group of different diseases, and Hodgkin lymphoma. So this is the simplest classification. We have non-Hodgkin lymphoma, which can be B-cell lymphomas or T-cell lymphomas, depending on the type of lymphocyte that they derive, and we have Hodgkin lymphoma. But you know well that things are much more complicated than that, and the complication comes from the real classification. The real classification, published in 1994, is the revised European American classification of lymphoid neoplasms, and it was the first classification that was defining clinicopathological entities that were characterized by their morphology, the immunological characteristics, the genetics, the molecular characteristics, and the clinical characteristics. So the more that we know about the molecular characteristics, the more that we learn about the genetics of different diseases, that results in more entities. And after several steps, this has resulted in the current classification, the WHO 2016 classification. So this is why, and this is only the B-cell neoplasm A form, this is why you have such a long list of entities, because as I said, each entity is defined by the characteristics, how they look under the microscope, the immunological characteristics, the chromosomal and molecular abnormalities, and the clinical characteristics. And this list that might look already quite long and detailed, you have to take into account that this comes from the previous classification, the WHO 2008 classification. The current one, the 2016, is even more complicated, and we will see that in a minute. So as I said before, the more that we learn about, for example, genetic characteristics, that sometimes results in this, in a different entity. For example, in the current MED-A, we ask about the presence of these chromosomal abnormalities, BCL2 or BCL6 rearrangement. And now we know that if those are positive, what we have actually is a different entity, is a different type of lymphoma called high-grade lymphoma with MYC and BCL2 rearrangement. This is the current classification, the 2016, only of B-cell lymphomas. And you can see this new entity that if we had not collected the data on the rearrangements, we wouldn't be able to identify it. And this is the rest of the lymphoma classification, the current classification, the T-cell lymphomas and Hodgkin lymphomas. So why is this important? Are we being too picky, trying to distinguish lots of different diseases? Well, it matters because the prognosis is very different. the molecular characteristics, the morphological characteristics, and obviously different, but also the clinical characteristics, the age in which this disease present, the behavior of the disease, but also the management and the prognosis is very different. And you can see here, this is an old study based on the real classification. So the origin of all this, which was, as you can imagine, much simpler, that there are some types of lymphoma that have an overall survival of 5 years of over 70%, whereas there are other types of lymphoma where the overall survival at 5 years is less than 30%. So it's really important to distinguish these different entities. And more recently, and this is regarding this new entity that I was mentioning before, the high-grade lymphoma with MYC and BCL2 rearrangement, which is a very, very long name. So for short, sometimes we call it double hit. As you can see here in this study, patients that were transplanted because of a double hit lymphoma had a significantly worse outcome than patients who were transplanted with a disease that had all the other similar characteristics, but without these chromosomal abnormalities. So moving on to the different specific entities, non-Hodgkin lymphoma is relatively common. In the UK, is the 6th most frequent type of lymphoma. But as I said, and as you've seen from the previous classification, actually non-Hodgkin lymphoma is a huge group of different diseases. And this is again is a bit old, is based in the real classification, but the summary is that the most frequent type of non-Hodgkin lymphoma is diffuse large B-cell lymphoma, and the second most frequent is follicular lymphoma. So patients with clinical with diffuse large B-cell lymphoma normally present in their 60s or 70s. Advanced stage is noticed at diagnosis in 50 or 60% of the patients, but bone marrow involvement is not very frequent. And in around 1/3 of the patients, the disease is primarily extranodal, so it appears in other sites of the body, not in the lymph nodes. And how bad is diffuse large B-cell lymphoma? Diffuse large B-cell lymphoma is clearly an aggressive lymphoma, and it's a type of lymphoma that would be fatal without treatment. But actually, it's been a long time now, longer than 40 years, since we've known that it's a disease that is potentially curable. And we know now that the best treatment to cure the disease at first line is R-CHOP or rituximab chemotherapy, as this randomized study showed almost 15 years ago now. This study was performed in patients aged from 60 to 80 years. And as you can see in these populations, around half the patients can be cured with R-CHOP. But there are still a proportion of patients in whom they don't achieve a complete response after first line, or they relapse. And for those, we know from an old randomized study that an autologous transplant is the best treatment option. So this randomized study compared chemotherapy versus transplant in patients who have relapsed or have not achieved a complete response after first line, and showed that those who received an autologous transplant had the better outcome. And this is the consequence of that we have been performing around 2,000 cases of autologous transplant for diffuse large B-cell lymphoma in the last 20 years. And as you can see, allogeneic transplant is not that much used. Follicular lymphoma, as I mentioned, is the second most frequent type of non-Hodgkin lymphoma, and it's a very different disease. It's what we call an indolent lymphoma, so it grows very slowly, and it can be present for a long time without causing any significant trouble. It's also a disease of middle age. The median age at diagnosis is between 50 and 60 years. The majority of the patients present with good performance status, in spite of the fact that in the majority of the cases, the disease is advanced at diagnosis, and in the majority of the cases with bone marrow involvement. As I mentioned before, is a disease that grows very slowly and can be present without causing any trouble for a long time. So that means that it is possible to live with the lymphoma. So to have the lymphoma and still be alive for a long time. So the disease that it's characterized by a long survival, but with multiple relapses, with the risk of histological transformation, meaning that when the disease comes back and you do a biopsy, you find another type of a lymphoma, a more aggressive lymphoma, normally a diffuse large B-cell lymphoma. And this has a very important prognosis significance, and that's why, again, on the MEDB, we always ask, is this lymphoma transformed from another one? And it's a disease that it is still considered incurable, at least with conventional treatment. So because of that, the management of patients with follicular lymphoma can vary from not doing anything, expectant management at diagnosis, to the more aggressive allogeneic transplant. And whether we choose one treatment option or another depends on many variables, such as obviously the age, comorbidities, the symptoms, whether it's at diagnosis or at relapse. And each of these treatment options might be appropriate in different circumstances in the same patient. And again, this is what we have seen in terms of transplant for follicular lymphoma in the last year. So it seems that there has been a decrease in the number of autologous transplant, although you know that this is always a bit incomplete, and normally with a few years this goes a bit higher. And many authors are arguing that this is because of new drugs, that new drugs are so good that we are not needing transplant for these patients anymore. I'm not completely convinced that this is true. And lastly, talking about the specific types of lymphoma, Hodgkin lymphoma, which is, you will be pleased to know that it's a more homogeneous disease, so there are only two subtypes, nodular lymphocyte predominant and classical Hodgkin lymphoma, and most of them are classical Hodgkin lymphoma. And in the UK, we see around 3 cases per 100,000 inhabitants per year. It's a disease that is characterized by a bimodal age distribution, with a peak in younger patients between 15 and 34, and another peak in elderly patients over 60, and with a slight male predominance. And it's a disease that can be cured in the majority of the cases. So again, this is data from the UK, Cancer Research UK, and you can see that at 10 years, 80% of adult patients with Hodgkin lymphoma are alive. Now, the same as in with diffuse large B-cell lymphoma, there are some patients who do not respond to first-line chemotherapy, or that they do relapse. And again, the same as for diffuse large B-cell lymphoma, we have quite an old randomized study, 15 years, but it's the study that we are still basing the management of these patients. So when patients relapse after first line, they can be salvaged with an autologous transplant. And in this randomized study, it was demonstrated that this is better than giving just more chemotherapy. And again, this is what we see in terms of the numbers of patients transplanted. There might be a slight drop in the number of autologous cases here. Again, I think that we need to see with in a couple of years if the numbers go down or up again. So in terms of the treatment options for patients with lymphoma, they varied from the most, let's say, conservative and conventional, such as radiotherapy, single-agent chemotherapy or combination chemotherapy, to the more aggressive as stem cell transplant, either autologous, allogeneic, with all the varieties of donors, or to the more modern immunotherapy, which includes monoclonal antibodies, which now is the routine, or CAR T cells, which is still experimental, or pathways inhibitors or targeted agents, which is most of when we talk about new drugs, the great majority of the new drugs are included in this category of pathway inhibitors or targeted agents. And what do we mean by that? So this is how the B cells work. They, to survive and to proliferate, they have a very complicated system of different molecular reactions and pathways. And if you block some of them, for example here, that can stop the cell from surviving and from growing. So this, what we call pathways inhibitors or targeted agents, what they do is they block in different ways these very crucial mechanisms of the cell to survive. And going back to the complexity of the classification, if we know more about the biology of the cell, of the specific lymphoma, we can know that for that specific lymphoma, one of these pathways is crucial. So if you block that one, the cell is not going to survive. But this can be different for another type of lymphoma. And that again emphasizes the importance of knowing about the biology and to recording that information, because sometimes these chromosomal abnormalities or molecular abnormalities are linked to susceptibility to a specific drug. So the families of new drugs that I was going to say we are using at the moment, but actually lots of them are still in clinical trials, but they are of interest are the PI3 kappa inhibitors, and the most frequently used are idelalisib, which is licensed, and copanlisib, which is still in clinical trials. Bruton tyrosine kinase inhibitors such as ibrutinib, which again, ibrutinib is licensed, and acalabrutinib is still in clinical trials. Checkpoint inhibitors such as nivolumab and pembrolizumab, BCL2 antagonists such as venetoclax, and new monoclonal antibodies such as brentuximab vedotin and obinutuzumab. Some of them, even if we call them new agents and new drugs, they are still already in the routine management of these patients. Some of them are still investigational. And again, as I mentioned before, some of these pathways are more important in a specific type of lymphoma than in other. So some of these drugs are used preferentially in some lymphomas. For example, idelalisib is mostly used and demonstrated in follicular lymphoma. I mean, not only, but mostly. Ibrutinib in mantle cell lymphoma, in CLL, in some subtypes of diffuse large B-cell lymphoma. Checkpoint inhibitors mostly in Hodgkin is where they have shown the better results. Venetoclax in follicular lymphoma, although also in CLL. Okay. And talking about new monoclonal antibodies, and again, even if I say new, these are, some of them are not so new anymore. Obviously, you know about rituximab, which that's part of the routine now, and you can see that depending on how they have been manufactured, whether they are chimeric, whether they are of murine origin, humanized or human, they have a hint in the name O, X, Zo, or O as in ofatumumab, although actually this doesn't change much what the indications are for. And in addition, there are different types of monoclonal antibodies depending on whether they are naked monoclonal antibodies such as rituximab, whether they are radioimmunoconjugate such as Bexar or Zevalin. So that means that the monoclonal antibody carries a radioactive particle, and that's what sort of makes the effect, or whether they are immunoconjugates, meaning that the monoclonal antibody carries a chemotherapy drug, for example, brentuximab vedotin. And some of these drugs have shown very, very interesting, very promising, maybe preliminary results. For example, idelalisib. This was the paper that sort of led to the licensing. In patients with relapse refractory indolent lymphoma, so patients with lots of chemotherapy before, the relapse rate was response rate was 57% with a CR of 6%, and the median progression-free survival of 11 months, again in patients that had been heavily pretreated. Another example is checkpoint inhibitors with rituximab, and this is in patients with refractory disease, with refractory lymphoma, so patients who were not responding anymore. So again, a response rate very good for this population, 66%, and the CR 52%, and the progression-free survival of 19 months. And another example is brentuximab vedotin given after an autologous transplant in patients with Hodgkin lymphoma to reduce the risk of relapse. And this study showed how it improves the progression-free survival. So all these results, as I said, are very, very promising and have led to a huge interest in these drugs. So the way that we can use these drugs in relationship with the transplant as a bridge to transplant, so for example in patients who are not responding more to chemotherapy to achieve a response good enough to proceed to transplant, in patients who relapse after transplant, or as in the case of the last study that I showed you, as a maintenance after transplant. But there are some concerns about that. There is the concern about the efficacy of the transplant after new drugs. So we sort of know what to expect from a transplant after chemotherapy, but because these drugs are so new, we don't know so well what to expect. And maybe the fact that these patients have needed these new drugs to achieve a response means the patient is not going to benefit anymore from a transplant. Another concern is the toxicity. Some of these drugs interact with the immune system, and especially in the setting of an allogeneic transplant, there is the worry that can trigger GVHD. And another, let's say, not concern, but a question is whether these drugs are going to reduce the role of transplant. And the people who are strong advocates of new drugs are very adamant that with these wonder drugs, transplant is not going to be necessary anymore. This is a list of the Lymphoma Working Party studies that we are performing, that we have performed in the last years involving new drugs. So you can see that it's I should have put the denominator, the number of studies, so that you can see that a big proportion of our studies are related to new drugs. And this is why it is so important for us that you record this well. And this is why the MED-A was changed a few years ago to incorporate this information. So to conclude, new insights into the biology of lymphoma leads to new entities, or subtypes with a worse prognosis, and sometimes to, it doesn't lead to new drugs for the identification of types of lymphoma that can be more susceptible to a specific drug. And there is, I would say that the main focus of research in the lymphoma field and transplant is the relationship between the new drugs and transplant. As I said, see how we can use them either as a bridge, see how we can use them safely after a transplant. So I thank you very much for your attention.
Do you have any questions? No? So at first I would like to ask or confirm how important is histopathology report in lymphoma.
It's massive.
Because sometimes we have patients of other centers. If they are from our center, it's not problem to look at it and find a special subtype of lymphoma. But sometimes it's not the same. So I think it's very important to ask the cooperative center to send, not described only, send the whole histopathology report because it's important to find the special subtype.
It's crucial, yeah, you're absolutely right. So even if we talk about non-Hodgkin lymphoma or lymphomas, if it was one disease, I hope that I convince you that it is not one disease, it is more than 60 different types. And it's a combination of the pathology report, but also the clinical characteristics. And frequently, 3 different pathologists wouldn't agree on the subtype. So having just the tick without knowing exactly where this comes from is not enough. And one of the main problems in the Lymphoma Working Party when we try to run a study, or we try to publish a study that we have performed, is the reviewer saying, how do you know that this type of lymphoma, that it's very rare and it's not so easy to diagnose? How do you know that the patients that are included actually had this type of lymphoma? And for some studies, if they are not big studies, we have gone back to the centers and asked for the pathology report. But if it was possible to get, the same as you get the HLA typing, to get the pathology report with each lymphoma, for each lymphoma patient, that would be ideal.
Okay, thank you. And also, I know that sometimes data managers complete lymphoma as other, not B, not C, and I know that there are few lymphomas in gray zone on other rare subdiagnosis, so I think it's good really have this report to put the right subtype.
Yeah, but I think that the most important thing is that if you have any difficulties with a sort of interpreting or knowing what the subtype is, talk to your clinician and ask, okay, tell me what type of lymphoma you think that it is. Tell me how I need to report this to the EBMT, because sometimes, even for clinicians, even for pathologists, you have a pathology report and you will say, actually, I'm not quite sure, it can be this or the other. So it's not as, sometimes it's very clear with the most frequent subtypes, Hodgkin lymphoma, follicular lymphoma. Diffuse large B-cell lymphoma is becoming a bit more difficult because the pathologists love to find new subtypes, and be assured that we are as upset with the pathologists finding new subtypes as you are with them, because it sometimes makes things more complicated. Sometimes it's very clear, but sometimes even for us it's not so clear. So if you have any doubts of what type of lymphoma this is, just ask your clinician.
Thank you. And also similar situation is with drugs. Sometimes it's easy to put their CHOP or R-CHOP at very known regimens, but sometimes there are new drugs, and if data manager can't find on the first step the name, they also choose other. So many drugs are below other, and that is not easy to select when you need it for studies, when we need it for national studies, etc.
No, the advice is the same as before. Talk to the clinician, but I realized that that's a problem. And actually, going through the Med-A form, I realized for this presentation that the names of some of the drugs that you have there, actually, they are the old names. So you know that when drugs are under investigation, they have, rather than a name, a code that it cannot be pronounced, like ABT and the number. And some of the drugs are still there. And to be clear, for some of the drugs, I had to check, oh, I don't know what it is. I need to check what it is. And also that sometimes you have a mixture of the experimental or the investigational name, the brand name, and the generic name. So I'm sympathetic. I realize that it's not a simple.
Sometimes it's not easy, but we can ask to add the new name of the drug to the promise. You can ask the London office or the national data managers to add the new drug, and then it's easy. Do you have any other questions? Nobody? So thank you very much,
Thank you.
Silvia.